Very, very excited for grand rounds today. I feel kind of funny doing this, introducing our chair, our esteemed leader, Dr. Bobby Chhabra, who's been running the show here as chair for what, 7 years now, 8 years now, but has been basically managing the hand patients at UVA and in this community for over 20 years. So I don't really need to introduce you much beyond that, Dr. Chhabra. I think you have the floor. Go ahead.
Great. Thank you, Winston. It's today was supposed to be the Morgan McHugh Visiting Professorship, and Dr. Warren Hammer was supposed to be here from the University of Rochester, one of our esteemed colleagues in the ASSH and a good friend of the department. But unfortunately, because of COVID-19, we had to make some adjustments. But it did give me an opportunity to give a talk that I actually have not presented to the department or the fellows or residents before, so I'm excited to do this, and then also give my second talk, which I think you all will enjoy, in the fact that Winston Guafmi was the one that actually helped me start my push toward popularizing an approach for distal radius fractures. So I'd like to first start with the experience I've had treating acute scaphoid fractures in high-level athletes. And the standard of care for this fracture pattern is, for the most part, you can treat and cast, but for the most part is screw fixation with one screw. That's the standard of care that's been accepted for decades. But there's some evidence now that is suggesting that there are better ways to fix scaphoid fractures, particularly in high-level athletes. So let me see how I advance. All right, so I have no conflicts with this presentation. So this is a case example. This is a 20-year-old male, high-level Division I NCAA basketball player who sustained this injury during a conference tournament game. And you can see on the imaging on the left that there's a non-displaced or minimally displaced scaphoid waist fracture. That's more evident on the subsequent MRI. There's also some signal within the scapholunate ligament, which suggests concern for scapholunate ligament injury as well. So what do we know about these type of injuries? So this was a non-displaced scaphoid waist with a questionable scapholunate ligament sprain. So the first decision is, do you cast or you treat these with surgery? So you need to consider very specific patient factors. One, time to union. What are the ultimate goals for this individual? What about return to play or return to activities? Is this the shooting or non-dominant hand in a high-level athlete? So I want to review a little bit of the literature here. So most studies show a high union rate of greater than 90% with close management of scaphoid waist fractures, particularly non-displaced scaphoid waist fractures. There is some debate on the duration of immobilization and whether to include the thumb or elbow. But for the most part, you can have a very high union rate with close management. Now, there's multiple randomly controlled trials that have compared casting with surgery. And surgery, for the most part, involves percutaneous fixation of these fractures or open reduction internal fixation. What these studies have shown is a decreased time to union, a quicker return to work and play, less early stiffness, and less early weakness. Currently, as I mentioned, the standard of care and most common surgical treatment option is fixation with one cannulated screw. And that's a screw which allows for compression across the fracture site and is buried within the bone and under the chondral surface. So this is one of the landmark articles from 2001, which compared percutaneous screw fixation or cast immobilization in non-displaced scaphoid fractures. This was done in the military population, so young, healthy population. There were acute non-displaced fractures that were treated with either percutaneous screw fixation versus casting. They were placed in a long arm thumb spike and transitioned to a short arm. So what was impressive, and this was a randomized controlled trial, so this was a prospective study, time to union was 7 weeks versus 12 weeks between screw fixation versus casting. and they were able to return to military activities at 8 weeks as opposed to 15 weeks. And there was no ultimate difference in the outcomes or patient-measured outcomes for these injuries. A subsequent follow-up in 2008, this was also a prospective randomized clinical trial where there were 60 acute scaphoid fractures treated with percutaneous screw fixation or a short arm cast with the thumb free. Time to union for screw fixation was 9.2 weeks, and for casting was 13.9 weeks. Athletes returned to play at about 6.4 weeks versus 15.5 weeks. Now, the athletes included 10 treated, the 10 that were treated operatively and the 8 treated non-operatively. So there was a statistically significant difference in the return to play. The strength and range of motion was better at all time points, better range of motion, better grip strength, better pinch strength for the treatment group treated with percutaneous screw fixation. So at this point, there was a trend toward treating these fractures with screws rather than treating them with cast fixation, even though there's a greater than 90% healing rate with cast fixation. Obviously, the importance of treating them with screw fixation was that it allowed them to heal at a faster rate. So healing is probably equivalent between screw fixation and casting, but healing with screw fixation is faster, and it allowed high-level individuals, military personnel, and athletes to return to play or return to work at a significantly sooner time point. So then there were some discussions on what's the best way to treat these fractures operatively. And the residents and fellows know that when we're doing these cases, I'm very persistent in when we're using one screw that you need to be within the center of the scaphoid when you place that screw, and you need to be perpendicular to the fracture site. So screw placement has to be that central screw placement allows for maximum compression across the fracture site. So there's been studies in the literature very recently about what's the best fixation for scaphoids. And many of them are biomechanical studies done in cadavers. So this study from 2018 in the Journal of Hand Surgery showed 30 cadaveric scaphoids. There was a wedge osteotomy at the waist created to simulate a non-union. And then one of 3 fixation types were used. Either 1/3/0 headless compression screw, 2 2.2 millimeter headless compression screws, or a scaphoid plate. I'm not sure many residents and fellows have seen plating for scaphoids, but some surgeons, particularly Seth Dodd down in in Miami, he uses plate fixation for almost all of his scaphoid fractures. And that's, in my opinion, a very technically demanding volar approach to the scaphoid, which is extensive but if you look at the biomechanical results of plate fixation, they're quite impressive as well. So this study looked at load to failure, load to 2 millimeter displacement, the energy absorbed, and stiffness. And the results showed that double screw, so 2 screws, and plate fixation were statistically significantly higher in all categories compared to a single screw. And there was no statistical difference between plate and double screw fixation. So we've been fixing these scaphoids with 1 screw, many because of the concerns, can you actually fit 2 screws into a scaphoid? And now you have an option, at least from a biomechanics study, that fixation is better if you use 2 screws or a scaphoid plate. There was another study in 2016 that was a biomechanical study in an artificial scaphoid model with an acute waist fracture simulation. And this looked at rotational stability. So one of the reasons that scaphoids go on to non-union is there's not enough rotational stability at the fracture site. And if you think about it, 1 point of fixation does not usually control rotation. And that was when I started, as I was treating these fractures, it just didn't make sense to me that you could get as much control as needed for a scaphoid fracture with just 1 screw. So this study showed rotational stability. And there were 3 groups. either one 2.2 headless compression screw, two screws, or a scaphoid plate. This construct was subjected to rotational forces and tested for torsional stability. And the plate and the double screw were superior to the single screw, with no difference between the plate and the double screw. So again, a rigid plate or two points of fixation with screws seem to provide the most biomechanical strength in these two cadaveric and an artificial scaphoid model study. There has been clinical work as well, and the retrospective study in 2017 treated 32 acute displaced waist fractures. So 22 patients received one screw, 10 patients received two screws, and the mean follow-up was almost 4 years. The outcomes were evaluated by various patient-reported outcomes measures, and of course, range of motion and grip strength. And the results, even though not statistically significant because of the small volumes of the cohorts, 91% healed with one screw and 100% healed with two screw. And again, there was no difference in range of motion, grip strength, pain, or outcome scores. So this was the first paper in the literature that reported using two screws for scaphoid fixation. And these were for displaced fractures. So these patients had open reduction at the fracture site and more extensive approaches. And even though they were small cohorts, using two screws suggested there was a higher healing rate. The one study in the literature that has been criticized because it's not a very a strong study from a research standpoint, but this was popularized and people started using two screws for non-unions more regularly far before they started two screws for acute fractures. So this study came out of Duke and in 2014, and it showed 19 patients all treated with two screw constructs for non-unions of scaphoid fractures and with a variety of bone grafting techniques. Their outcomes, and this was a retrospective study, showed 100% union rate with no issues, no revisions, and all athletes returned to their previous level of play. So their conclusion was two screw constructs for scaphoid non-unions are safe and effective and can be used successfully with a variety of bone grafting techniques. So this led to the popularization of scaphoid non-unions, and those of you who have rotated on the hand surface, you see that scaphoid non-unions are more common than scaphoid fractures in our clinic because this fracture, this injury is often ignored, or people have a wrist sprain, or it's missed on initial x-rays because it's non-displaced and follow-up x-rays and evaluation are not obtained. So this popularized the use of the two screws for non-unions, but there has really not been overall acceptance of using two screws for acute fractures, and I'll explain the reasons for that in just a moment. So let's go back to our case. This is a high-level athlete, non-displaced scaphoid fracture, and questionable SL injury. So based on the data that I just showed you, surgical management is very reasonable and likely preferable to closed management for two very simple reasons: higher union rate with an acute fracture with screw fixation and quicker return to play. And of course, in certain athletes and certain levels of athletes, not only is quicker return to play important, but range of motion, grip strength is absolutely critical. And literature has suggested that screw fixation of scaphoids gives you better overall outcome for grip and pinch strength and range of motion. So these are all critical, particularly for an individual who has a pro career ahead of them. So now the next question becomes, okay, you need to fix this. How are you going to fix it? Because there's debate in the literature on the approach to the scaphoid. Should this be a percutaneous approach, which is very popular, and as you can see from the literature I presented, all these papers had percutaneous approaches to the scaphoid for the waist fracture. Should this be a mini open approach or a formal ORIF? ORIF is not needed for non-displaced or minimally displaced scaphoid fractures. It's usually overkill in terms of exposure. You do not want to devascularize the bone and injure the intrinsic or extrinsic wrist ligaments, particularly in a high-level athlete. The more extensive your exposure, guess what? The more wrist stiffness you may have post-op. And this is something I could not afford in this particular individual. So for this case, we've ruled out casting and formal ORIF. So the decision next was percutaneous screw fixation versus mini open approach. So relying on the literature becomes very challenging. There's no consistent definition for what's a mini open, and percutaneous screw and mini open techniques are often grouped together. And they have mixed indication, different fracture acuity, different patient populations, which makes the decision-making about the best approach for this even more unclear. So again, let's look at the literature. Tom Trumbull showed that screws placed down the center axis of the scaphoid have improved biomechanical rigidity and a shorter time to union. So that's what I discussed again. Center axis of the scaphoid is ideal for a single screw construct. Chan and Kim demonstrated in a cadaveric and clinical study that the dorsal approach allows for screws that are more parallel to the long axis of the scaphoid and for better placement down the center axis. So in my mind, the best approach for this is from a dorsal approach. Several studies have showed complications related to percutaneous approaches. So Adamani showed that the dorsal percutaneous approach, 17% of the screws in a cadaveric specimen were prominent under live and static fluoroscopy. So they did it percutaneously, they buried the screws, or they thought they buried the screws, and ultimately the screws were not buried when they opened up and examined the specimens. And what's also important to know is the superficial sensory radial nerve, the index EDC and EIP were all within a few millimeters of placement of the guide wire. So remember, you drill over the guide wire, so all of these structures would be at risk. Bushnell showed a 12% hardware complication rate with a dorsal percutaneous approach. Those of you who have done percutaneous approaches, you have to flex and extend the wrist, and you can break your guide wire. And there's nothing more discouraging than breaking your guide wire within the scaphoid and not being able to get it out. Slade reported a EPL rupture with a dorsal percutaneous technique because often the EPL is right there, and you place your guide wire and you drill through over your guide wire, you can drill through the EPL. So in my mind, percutaneous approaches should not be used because of the risk. And because of the fact is you really don't know whether your screws are below the chondral surface. And if they're not below the chondral surface, you're gonna wear away the radial chondral surface, radial cartilage, and develop a site of scaphoid arthritis. So you need to be assured that the screws are below the articular surface. And you cannot do that with a percutaneous approach. So finally, in this individual, we decided on surgery, we decided on a dorsal approach, and we decided that this should be done with a mini open approach. There were several other advantages for me using this approach. It allowed direct visualization of the scapholunate ligament. And remember, this individual, there was a concern for a scapholunate ligament sprain or injury. And I wanted to treat that if I needed to, if there was a significant tear. You can't do that through a percutaneous approach. And for me, having a dorsal mini approach allowed redirection of the guide wire for fine tuning of my trajectory because there was no soft tissue tethers that were getting in the way. And as I mentioned before, I have gone to using 2 screws based on the literature that I presented. And intuitively, it makes more sense for me to have 2 screws for rotational and torsional stability in these individuals. And it allows me to more comfortably rehab these individuals with that fixation construct. So having a mini open approach allows me to place 2 screws easier. And what's most important at the end of the case, which is something that I do for all of my scaphoids and high-level athletes, And as many of you know, I've had a run of these in our UVA basketball players over the last few years. But I confirm and document with intraoperative pictures that are put into the chart, into the electronic medical record, that there's no screw prominence, because every time these high-level individuals, I have to talk to agents or their medical individuals during the draft, and there's always questions about whether the screw is actually underneath this articular surface, because on plain x-rays, they can appear to be proud. So this is a busy slide, but it just shows the approach for this. So a small 3-centimeter incision over the SL interval, avoid the superficial sensory nerve, identify the EPL, I vent the distal portion of the third compartment, identify and retract the EPL and index extensor, make a T-shaped capsulotomy from the rim of the distal radius, but spare the DIC ligament distally, the dorsal intercarpal ligament, and don't disrupt the scapholunate or dorsal blood supply. So you don't want to go to this distal scaphoid tubercle, otherwise you can disrupt the blood supply. Remember, the blood supply is retrograde from distal to proximal. You flex the wrist, visualize the SL ligament, place your guide wire just radial to the SL, aim down the thumb along the metacarpal axis, and then confirm placement of your screw. Because you have a mini open, you won't bend your wire when you extend this wrist to get your imaging. You can fix with either 1 or 2 screws, and then you can see at the bottom right of the slide is the picture I put in the chart of the screws, and I used 2 for this individual, placed underneath the articular surface, and I put this to confirm that there will be no hardware complications from screw prominence. And then standard closure after tourniquet is down. I do close with non-absorbable sutures, the T-capsulotomy, and put them in a short arm thumb spica split. So this mini open approach is not a panacea for all scaphoid fractures in terms of approach. Indications apply. I use it just for non-displaced waist fractures, some displaced proximal pole fractures, and waist non-unions without AVN, humpback, or carpal collapse. It's also a great option to evaluate the scapholunate ligament, and it's much easier to place 2 screws with a dorsal mini approach than through percutaneously. I do not recommend placing 2 screws with percutaneous approaches. You will have significant problems, and I assure you, you will have some complications if you try to do so. But mini dorsal approach is not appropriate for distal pole. You usually go retrograde if you need to do that. And then with any severe combination, humpback non-unions, chronic scaphoid non-unions, you should use a more formal dorsal or volar open approach. So back to the case. For this individual, I used 2 3.5 headless compression screws. This individual scaphoid was quite large. And normally, if you have a non-displaced scaphoid in an average male, a size 24 screw is usually the longest you can use. But in this individual, I used a 28 screw. Obviously 6'9" individual, so probably a bigger scaphoid. So I used a mini open approach. It was easier and more accurate for screw placement, less likelihood of prominent hardware or iatrogenic tendon injury. And I could directly evaluate the scapholunate ligament during my exposure, which was intact. The 2 screws were used as opposed to 1, allowing more compression, more rigidity, more rotational stability. And to me, that gives me peace of mind that I can start earlier range of motion and strengthening with much greater confidence. And by definition, you're not reliant on the center axis placement, as has been shown to be optimal for single screw constructs. So you have a little bit more flexibility as to where you put your screws. And when you put these screws in, you don't just put in one completely and then put the other one. You put in one guide, you put in both guide wires, and I either have the screws parallel on the AP or parallel on the lateral. So you either need, you want to have them parallel in one plane. And depending on the size of the scaphoid will determine which plane that is. So I put in the both guide wires, make sure I'm happy. I drill one, I place the screw about halfway down across the fracture site. and then I drill the other one, and I place the second screw, and then I place that down just across the fracture site, and then I alternate tightening both screws, because if you tighten one screw more than before you tighten the other, you'll get asymmetric compression at the fracture site. So you need to tighten both of them as you're putting them down sequentially, and so that they compress symmetrically across the fracture site. So for this individual, this is my, and for most individuals I treat with 2 screws, this is my post-operative approach. So post-operative plan, usually 3 weeks and just a regular splint or cast, and then I take them out of a immobilization and start range of motion and grip strengthening at 3 weeks. And I just don't have them I have them do active range of motioning, even light passive motion. I don't let them do any axial weight bearing. And then at 6 weeks, once they've obtained full motion, and this individual had full symmetric extension, supination, pronation, lacked a little bit of terminal flexion, which he regained, and I started him with basketball activities without protection at 6 weeks. And he had full range of motion and full return to sports by 9 weeks. He had completely.
No.
You might want to mute your computer, whoever's.
That's Victor. I'll take care of him.
Yeah, there you go. So this has been my personal experience, and this is I know many of my partners also use 2 screws now, so this does not include their cases, but we've started doing significantly more cases, acute fractures with 2 screw fixation now. But my personal experience, and I just looked this up last night, but I've done 20 of the 40 acute scaphoid fractures in the past 5 years. I fixed half of them with 2 screw constructs. And, you know, again, I can't always put 2 screws into a scaphoid, particularly if they're smaller individuals. So you have to be very cognizant of whether you plan to put 1 or 2 screws in at the beginning of the case or right immediately during your dorsal approach and initial exposure. But half the people I've fixed with 2 screws, there have been primarily athletes or high demand individuals, and all have healed. And again, there's high healing rates for waist fractures, but again, 100% healing rate is uncommon. But I do think that, and I've treated all of these individuals with the same post-operative protocol. So I move them early, start range of motion, and grip strengthening early. So this paper has, this technique paper has been accepted to Journal of Hand Surgery and will be coming out, I believe, next month or in the next month or two. But it describes this approach and again, reviews the literature as I've done in this talk as to why it makes more sense to use 2 screws instead of 1, not only for non-unions, which is commonplace, but for acute fractures as well of the waist. So in conclusion, just to review, surgical fixation of scaphoid waist fractures leads to earlier time to union, earlier return to high demand work or athletic play, less early stiffness, less early weakness when compared to closed management. 2 screw fixation for scaphoid waist fractures and non-unions is safe and effective in limited published clinical outcome data. And 2 screws is biomechanically superior to a single screw in non-union and acute fracture models with regard to rotational stability, load to failure, load to 2 millimeter displacement, rigidity, and energy absorption. 2 screws may allow for earlier range of motion and theoretically could lead to higher union rates due to increased stability, although more clinical and prospective data is required. And 2 screws is technically demanding, although less so than plate fixation in my hands. So it obviates the need for direct center long axis screw trajectory and has been shown to be, which has been shown to be ideal for single screw constructs. And I would use this with a mini open approach as opposed to percutaneous fixation to allow for improved guide wire trajectory control and also to ensure that you do not have prominent hardware at the end of the case and you do not have iatrogenic injury to extensor tendons or the branches of the superficial sensory radial nerve. So that is why I use 2 screws. It is not commonplace. for acute fractures, but I hope that it will become more commonplace, particularly when this article comes out. And I have become more and more confident, particularly over the last 3 to 4 years, of treating scaphoid fractures with 2 screws, particularly in high-level individuals. It is nerve-wracking because you can have the proximal portion of your fracture, if you're not careful, blown apart. So there is a high level of stress, not only because many of these individuals are high-level athletes, but placing these screws and ensuring that you do not fragment the proximal portion of your scaphoid as you're placing the screws is a concern, but obviously this should be done by people who've had experience and feel comfortable doing these cases. But I'm happy to answer questions now, but that again is why I hope to popularize 2 screw fixations, particularly in high-level athletes around the country. And I think there's enough support from a biomechanical standpoint. There's just not enough clinical literature out there to say that this should become the standard of care just yet. Questions?
Bobby, that was awesome. Thank you so much. No question, you've been the MVP of our basketball team in the past few seasons. A couple questions from the crowd through the chat board. If healing of the scaphoid is known to be tricky, why do we wait until it's non-union to do bone grafting? Why not that be part of the initial treatment approach? Is it an insurance authorization issue or a clinical reason?
So that's actually a very good question. So one thing that I did not mention in my in this talk, but I do mention in the article that's coming out in the Journal of Hand Surgery in the next couple months, is that I actually placed demineralized bone matrix down the screw holes before I placed the screw. So if you use, or some sort of demineralized bone matrix component, but the reality is scaphoid waist fractures have a very high union rate, and bone grafting is not necessarily indicated. Now, there are times when bone grafting is indicated. If you have volar comminution and you have a humpback deformity, even in an acute fracture situation, often you need to correct that humpback, and that may require a volar approach. So again, what I discussed was non-displaced or minimally displaced scaphoid fractures with minimal comminution, waist fractures. But you can use acute bone grafting. And in these cases, I use a little angiocath, and I've already drilled my hole. And before I put the screw in, I squirt some bone graft substitute into the holes, and then I place my screw with the thought that the bone graft will be pushed into the fracture site to allow optimized healing. But there is no indication to bone grafting a displaced or comminuted scaphoid fracture that has a humpback, because often bone grafting can help correct that humpback deformity.
Great. Next question. Awesome talk. How often are you now only using a single screw, and what are your indications? Patient type, scaphoid size, fracture type, from Dr. Brockmeyer.
Yes, great question. Again, as I mentioned, everyone's scaphoid size is different than the other. So I can say this publicly because it was out in the press, but Kihei Clark's scaphoid is different than DeAndre Hunter's scaphoid, right? So the size of the scaphoid, the size of the individual determines whether I'm even capable of putting 2 screws in. And I try to use 3.5 millimeter scaphoid screws in these individuals. So these are big cannulated screws. So it really depends on the size of the individual and the fracture pattern and how proximal the scaphoid fracture pattern is. If it's very proximal, I don't want to put 2 screws, or I'm very careful putting 2 screws in, or I'll use 2 2.2 millimeter screws as opposed to a 3.5 millimeter screws. It really depends on the size of the proximal portion of the scaphoid, the size of the individual, and then whether I can actually fit 2 screws within the scaphoid. In some individuals, I put 2 screws in, and you look at the lateral x-ray, you're like, you basically replace the bone with 2 screws. So you really need to be careful and make that determination based on the size of the screw and the size of the proximal fragment, and make sure you use, and that's why I use, I showed you my disclosure, so I have no relations with Arthrex, but I use the Arthrex FTS screws because they have more cannulated options for me that I can mix and match. I've put a 3.5 millimeter and a 2.2 millimeter screw into an individual because that's what was dictated by the size of the scaphoid.
From Dr. Miller, I want to share that radiographs should be taken immediately post-op to allow for later comparison. That was a comment, not a question.
Yes, so I make sure that the fluoroscopic images are in the chart as well. So if you look at these individuals, not only do I take the picture and of the screws buried underneath the articular surface, right, and put that into the chart, but I take the fluoroscopic images as well and put those into the chart as well. And these individuals I see at about within a few days of surgery to just check their wound and get plain films early as well. But you're right, you need to make sure you have adequate radiographs very soon, particularly in individuals that will be playing at the next level. And I do not allow these individuals to return to full activities until I get a CT scan that confirms healing. You need to have that CT scan, and you need to convince the scouts and so forth that they've healed and that their articular screws are not going to cause problems, or their screws are not going to cause problems because of articular prominence.
Yeah, the screws sometimes, they look like they're underneath the cartilage on the clinical picture, but when you get the CT or the X-ray, they appear to be proud. Do you ever have problems with that? I know in the knee, sometimes they look awfully proud on the CT scan. You wonder if you need to take them out just by virtue of that they're different than the surrounding cartilage.
So that's the exact reason why I take that intraoperative picture and put it in the chart, because every one of remember, there's at least 2 to 4 millimeters of cartilage on each end of the scaphoid. So even though your CT suggests they're prominent, there is cartilage there. So again, you need to confirm and verify that they are below the cartilage. Always, when you get subsequent x-rays, always compare the position of the screw to the previous x-ray to make sure it hasn't shifted in any way, in any regard. But for the most part, as long as they're progressing and they're not symptomatic and they're making progress and they've healed, and there's no lucency around the screws on the radiographs, and the screws haven't migrated on subsequent radiograph evaluation, then you should not have to worry about screw prominence, as long as you've confirmed intraoperatively and put that picture in the chart that they're below the articular surface.
So Anuj asks if you get CTs to confirm union before allowing anyone to return to full sports.
Yes, always. I get a CT scan. Not necessarily someone who's not a high-level athlete. If you show healing with subsequent x-rays, that is perfectly fine. But in these college athletes who have potential to play at the next level, I always get a CT scan to confirm healing before I let them return to full unrestricted activities. And you need to document that before any scout will even, or any team doctor at the next level will even consider them.
Dr. Ramos asks, do you try to get the screws parallel on both the AP and the lateral views?
No, so they can only be parallel in one view. So they're either parallel in the AP and sitting on top of each other. So yes, I try to get them parallel, but you're either going to see, they're going to look like, if you can see 2 screws on the AP, the lateral, they look like it's 1 screw because of the way they've been placed. Or the opposite. If you see 1 screw on the AP, you'll see on the lateral, there's 1 dorsal and 1 volar. So you try to put them parallel in both planes, but by doing so, you will see that they overlap in at least one plane. So you can see in this x-rays here, you can see 2 screws on the AP, but on the lateral, they look like you only have 1 screw because how they were placed. So they were placed exactly parallel in the AP plane. And then when you get, so you can either have the x-rays look like this, or the x-ray will show what appears to be 1 screw on the AP plane and 2 screws on the lateral plane, 1 dorsal, 1 volar. So you want to be parallel in at least 1 plane to maximize your fixation.
So from Dr. Didak, does the biomechanical strength of 2 screws influence how you cast or splint these athletes for activity?
So that's a great question, and Dr. Didak knows the answer to this, and I'm glad he asked it. So in the most recent individual for this year, was a non-shooting hand, we were able to take his thumb out of a cast and allow him to play, right away because it was a non-shooting hand. So with 2 screws, I feel much more comfortable taking the thumb out, and I do not include the thumb in immobilization, and that gives someone more capacity to return, even in the very acute stages where and play with protection at a much earlier time point. The standard of care for most of these fractures treated non-surgically is to include the thumb. And with 1 screw fixation, what I mentioned about rotational stability, it's not there with 1 screw fixation, in my opinion. So you need to include the thumb if you're going to only put in 1 screw.
So from our resident AVN expert, what do you do if AVN occurs, from Dr. Kwanjan Kui?
So if there appears to be AVN, so these salvages are tough, right? You got 2 screws in. So the goal here is that if you have fixation that's still rigid and you're starting to get early non-union, I will just go bone graft them, either vascularized bone graft or non-vascularized bone graft. But non-union usually occurs because you did not correct the humpback deformity, or you have a very proximal pole scaphoid. Waist fracture non-unions are pretty uncommon. And if your fixation is intact, you can just bone graft, just like you would take care of a delayed union somewhere else in a long bone or in a periarticular fracture. You can just bone graft if your fixation is okay. But if you have a more proximal fracture that you're getting AVN, we're moving toward treating those with medial femoral condyle free vascularized grafts, and that is what we're doing for more of these proximal pole AVN fractures. If you have concerns about fixation. So there is a concern about using this technique. If it goes on to AVN, then the salvage procedure for this is not easy. So that is one of the reasons why people have not adopted this technique more broadly, because of concern for salvage.
Dr. Paramal, if you cannot use 2 screws, only use 1 screws in high-level athletes, do you post-op protocol the same?
It depends on whether it's a stable, whether it's a waist fracture that's non-displaced, and how happy I am with my fixation. And then it also depends on the placement of the screw. It has to be center, perpendicular to the fracture site. And if it is perpendicular to the fracture site, and it is, I have excellent compression with 1 screw, and I like where I am from the stability standpoint, I actually will consider using this more aggressive therapy protocol. However, I often, in that case, I may wait till 4 weeks before I start range of motion and grip strengthening in these individuals, and I may immobilize them a little longer. But if I'm completely happy with the central placement of the screw, compression at the fracture site, it's a non-displaced fracture, I will use the protocol that I have on the slide there.
Dr. Whipple, do you have a question? You unmuted yourself.
Yeah, thanks, Dr. Chhabra. Excellent presentation. Could you comment on the prognosis for disruption of the proximal pole of the scaphoid using 2 screws, the prognosis for disrupting that cartilage?
So you just have to be very careful. And again, I don't make the decision of using 2 screws as opposed to 1 until I look at the proximal pole and I determine whether I can put the screws in. Remember, the drill, you don't want to, you can easily put your guide wires, and then when you drill, if you put them too close together, you're going to create one drill hole, and you can't put 2 screws. So you can see from how in this individual, after placement of the screws, there's a bridge between the 2, so you are in 2 different tracks. So you need to make sure that you do not disrupt, that you don't put the guide wires too close together. So otherwise, you're going to disrupt. You're going to have 1 screw hole that's going to be large, or you're going to disrupt and fragment the proximal pole. So you really need to make sure that you can actually you have to check the screw heads and make sure that you can actually place these screws. So proximal pole fractures, putting 2 screws in can be very challenging. And I usually use smaller caliber screws in that scenario and not a 3.5 caliber screw.
Awesome, Dr. Chhabra. You've done for scaphoids what Dr. Andrews did for ACLs. Everybody thinks Adrian Peterson came back in 6 months from an ACL, so that's what the athletes are asking for. I know athletes all around the country are looking at UVA and seeing why these athletes get back so fast, and clearly you've got something figured out here. So thank you for what you've done for this. I think we're all done with questions here, so we'll move on to the next talk, if that's okay.
Yeah, absolutely. Let me,
You see these athletes go down with, quote, risk injuries, risk fractures out for 6 to 8 weeks or 3 to 6 months, whatever it might be. And in a UVA, the expectation is they might miss a game or two, it seems. So,
well, that's my worry now. Is
yeah, congrats. Congrats for setting that high standard that's going to be hard to achieve every time.
Yeah, so we'll see about that. So, all right. This may not be as interesting to as broad a population, but I do want to.
Real quick, Bobby, share your screen.
Sorry, I didn't do that.
I'm not seeing it. Unless.
Let me get back to. I must cut the Zoom out. Here we go.
So while I was loading this up, residents, Dr. David Craig's going to run case logs mid-month, so, and by noon today, so please update your case logs if you haven't already. All right.
Got it now.
Seeing your screen. Yep, you got it now.
All right.
Oh my gosh, you have a shout out to me. I'm embarrassed.
Yes. So I just want everyone to know that before Winston went to the dark side, he was considering being a hand surgeon. The reason I'm giving this approach, this talk, and I hope the sports folks stay on board, is Winston helped me tremendously in what has been a lifelong ordeal in trying to popularize an approach that is not the standard of care in the country or in the world for the treatment of distal radius fractures. But I am making progress, and Winston is one of the biggest reasons for my commitment to doing this, because he helped me get this started when I was a young faculty member, and he was a very young resident. And I'll also say that his father is the one that really made me decide that I was going to make this happen, whether no matter how long it would take.
Can I pause you for 1 second, Bobby,
Yes.
to tell you my perspective? So I'm a visiting medical student here from UVMS 2006 or 2005. I'm not quite sure 2006. And I'm sitting there at lunch with the program director, Dr. Bobby Chhabra, and he's looking at my ID, and I see him kind of like curling his brow. He's like, Gwathmey, is your dad Frank Gwathmey? I'm like, yeah, that's my dad. He's a hand surgeon down in Norfolk. And this is like one of the first times I ever met Dr. Chhabra. He goes, your dad absolutely crucified me on the podium of the VOS last year when I tried to present this hybrid ORIF distal radius with carpal tunnel release. He basically just crucified me up there on the podium, and I'm sat there curling up into my seat like, well, I guess I'll cross UVA off my list of places to go. So I appreciate the fact you give me a shout out after all that.
So let me tell you why I got you involved in this project. It's because of your father, because I wanted to say to your father, and I'll explain this later in the study. So let me go ahead and present this. So again, many of you who've worked with me over the years know that I release the carpal tunnel prophylactically for every distal radius fracture that I treat with a volar plate or use a volar approach. That is not the standard of care anywhere. And I've been fighting for 20 years to make it the standard of care. And I will review what I've done to try to popularize this technique over this time period, and why I think it's still very important. And to just full disclosure here, talking about disclosures, I have none with this conflict, but I can't even get two of my partners to do this approach. But I have one partner that does do this approach, but he trained here, so he learned it from me while he was a resident. So let me talk about distal radius, carpal tunnel syndrome with distal radius fractures. So acute carpal tunnel syndrome is seen in 5.4 to 8.6% of distal radius fractures. And Winston, I want you to recognize some of these slides, because you put this talk together when you were a chief resident. So I went back and found this talk and I added to it. So again, the importance and contributions of Winston Gwathmey, the hand surgeon to be that went to the dark side. So again, carpal tunnel syndrome is common in distal radius fractures, and the etiology includes fracture displacement, hematoma, or edema within the carpal tunnel because of the injury. And median nerve, so the problem is a median nerve contusion presents with very similarly as a carpal tunnel syndrome. But median nerve contusion, there's non-progressive symptoms, and in carpal tunnel syndrome associated with distal radius fractures, there's progressive carpal tunnel symptoms. And the residents know that if you reduce the distal radius, the carpal tunnel symptoms usually improve if they present with acute carpal tunnel symptoms associated with a distal radius fracture. So the first thing to do is reduce these, and usually the carpal tunnel symptoms resolve. If they have a median nerve contusion, they don't have progressive symptoms, and once you reduce them, you can feel comfortable sending them out of the ER because they are stable. If they have median nerve symptoms on presentation and you reduce them, and it's related to acute carpal tunnel syndrome, the vast majority of them resolve with time very quickly. But in very high energy injuries, they may continue to progress despite reduction, and surgery is indicated. So when do you do a carpal tunnel release? It's very clear if they have progressive symptoms, right? If they have progressive symptoms despite a reduction of your distal radius, you do a carpal tunnel release when you fix their radius, and you do it acutely. So you divide the transverse carpal ligament to release compression on the median nerve, and you can do it through various techniques. So this is the standard technique. You do a conventional carpal tunnel release with an incision in the palm, and then you use a separate incision to place your volar plate or whatever fixation you're using for your distal radius. You can also do an extended volar incision across the wrist. So you just combine the carpal tunnel incision with a long incision across the wrist to fix your distal radius, and you just do it through one more extended approach. I do endoscopic carpal tunnels routinely for non-traumatic related carpal tunnel syndrome, but I do not recommend doing an endoscopic carpal tunnel release with a distal radius fracture. The anatomy is too distorted. There's hematoma within the carpal tunnel. You're going to cut the median nerve if you're trying to do this endoscopically, so that's not recommended. And one of the inherent risks of doing an extended approach into the palm is you get pillar pain and violation of the glabrous skin, and you can injure the median nerve recurrent branch. But if you have acute carpal tunnel syndrome with a distal radius fracture, you have to release the carpal tunnel, and you can do it through various methods: 2 incisions, 1 extended incision, as I just mentioned. Obviously, everyone knows that volar plating is very popular for distal radius fractures. So when I was a fellow, I worked with one of my attendings who showed me an approach in a lab, and it fascinated me because I learned the anatomy of the wrist in a way I'd never seen it before. And I started thinking, is it justifiable to just do a carpal tunnel release during volar fixation in patients without symptoms of acute carpal tunnel syndrome? To me, I do things that allow me to sleep at night. So, and I'll explain this a little later, but people can get carpal tunnel syndrome post-operatively. And if you've done a case with a 24-hour regional or 36-hour regional block, there's a chance you don't know they have acute carpal tunnel syndrome because they have a regional block and you've sent them home from the outpatient surgery center. So, and then what I've noticed was a lot of people had subclinical carpal tunnel syndromes that presented as a CRPS picture, particularly the geriatric population. And they had stiffness for a prolonged period of time. And I would never understand why they weren't improving with therapy. And what's the #1 finding with CRPS is stiffness. It's not necessarily pain. So I started thinking that maybe the reason people were not recovering as fast as they thought they would is because they had subclinical carpal tunnel syndrome after fixation of a distal radius fracture. And maybe we can treat that by just releasing the carpal tunnel and decompressing the median nerve every time you fix a distal radius fracture. So that is complete heresy if you look at the literature. Prophylactic carpal decompression during distal radius plating, is it justified? This was a study from 2001, 69 patients, standard ORIF versus ORIF with prophylactic carpal tunnel release, 24 patients. They did a carpal tunnel release with extended distal Henry approach across the wrist crease, and the literature showed that prophylactic carpal tunnel release increased your risk of carpal tunnel syndrome twice as much as if you didn't release the carpal tunnel. So the conclusion, and this is a paper that I've been fighting my whole career, is that prophylactic median nerve decompression does not alter the course of median nerve dysfunction and may increase postoperative morbidity. Of course, in 2008, there was another paper that supported that. So this was 2 surgical approaches for distal radius fractures. while volar plating, 174 patients, standard distal Henry approach versus a direct volar approach, extended approach for prophylactic carpal tunnel release. And carpal tunnel release were none in the standard group and 4 in the prophylactic group. The direct volar approach to the distal radius with routine carpal tunnel release should be abandoned because it is associated with increased rate of temporary and persistent median nerve irritation. Now understand, these are not individuals that come to the OR with carpal tunnel syndrome or acute carpal tunnel syndrome. These are people that don't have carpal tunnel syndrome and have a distal radius fracture. And the recommendation based on these 2 papers was you should never prophylactically release the median nerve or do a carpal tunnel release if they do not have carpal tunnel symptoms. So if you look at these 2 studies, the surgical approach contributed to the post-op median nerve dysfunction. Adamala's study they did an extended incision on the ulnar side of the thenar eminence for patients who had the carpal tunnel in decompression. This is a very extensive approach. And Latman used a longitudinal midline incision on ulnar to the flexor tendons. And the median nerve was mobilized and carefully retracted radially. So they manipulated the median nerve in both of these approaches. And in my mind, that is what resulted in the postoperative median nerve dysfunction. It was the surgical approach where they manipulated the nerve. Latman even wrote in the article, direct nerve manipulation and retractor-related nerve irritation are the most plausible causes of this problem. So, again, this is my journey through this issue. So there was plenty of literature that said doing a prophylactic carpal tunnel release during your exposure is contraindicated. But I just kept thinking, I think I can do this safely through the same incision that I'm using to put my volar plate on. And the reason I was thinking that way is because of this man, Bill Sanders, was one of my mentors at San Antonio. He passed away several years ago. Very eccentric individual. He thought outside the box all the time. And he was one of the most brilliant people I worked with, but very eccentric. He unfortunately committed suicide several years ago. But he described this approach, which he used exclusively in the workers' comp population for carpal tunnel releases, because workers' comp carpal tunnel releases with incisions in the palm have a fairly poor outcome because of pillar pain, sensitivity of the scar, and difficulty to return to work. So he did this all in the lab, and this was published in 1997 in the Journal of Hand Surgery, where he looked at the radial insertions of the transverse carpal ligament. And this was termed the flexor carporadialis approach to the carpal tunnel. So there is a superficial portion of the transverse carpal ligament that coalesces with the FCR, and there is a deep portion that coalesces with the FPL. Remember, the FCR is outside of the carpal tunnel. The FCR is inside of, the FPL is inside the carpal tunnel. So he suggested that you can actually release the carpal tunnel from the radial aspect of the transverse carpal ligament, as opposed to the more standard midline or just ulnar portion of the transverse carpal ligament. So these were MRI images that show before and after transverse carpal ligament release, and you can see how the transverse carpal ligament is released, and then here is where the carpal tunnel incision is. So the median nerve is protected because you're completely radial, so you don't have to worry about a recurrent branch of the median nerve, and you don't have to worry about an anomalous motor branch of the median nerve because you're completely radial. You do have to worry about the palmar cutaneous nerve, but this was a radial-sided release of the carpal tunnel. This was not a standard approach to carpal tunnel release. And in his study, he did 87 patients with preoperative carpal tunnel syndrome. This was non-trauma related carpal tunnel. And the FCR approach to carpal tunnel release couples the advantage of direct visualization of carpal tunnel contents with decreased disruption of the palmar skin, thereby reducing pillar pain without increasing the risk of surgical complications. So understand, this approach is done with an incision in the volar forearm. You never cross the wrist crease and you're never in the palm. So I started thinking, why can't we just do this when we approach a distal radius fracture? Because it's a very similar volar approach. You just have to extend underneath the skin to release the transverse carpal ligament. So of course, Orbe in 2001 developed the volar locking plate. Hand Innovations, he sold that company for $96 million to DePuy Synthes. But he used to do a FCR approach to the distal radius, but not release the carpal tunnel. So that's when I started thinking, okay, I can combine these two approaches, what Dr. Sanders taught me and what Dr. Orbe has popularized in the literature for distal radius fractures. And that way I can release the carpal tunnel every time I do a distal radius through the same approach and not cross the wrist crease. So I use a Brunner type incision because it allows me to make it shorter. The FCR tendon is exposed and mobilized. And then the superficial limb of the transverse carpal ligament, which inserts on the FCR tendon, is divided up to just past the trapezial ridge. The FPL is identified, which is in the carpal tunnel and retracted ulnarly to protect the median nerve. And the deep limb of the transverse carpal ligament, which inserts, essentially coalesces with the FPL tendon sheath, is divided. So you're dividing the superficial and deep portions of the transverse carpal ligament in between the FCR and FPL. And you visualize the tendons and you go ahead and you can see that the FPL is retracted ulnarly, the FCR is retracted radially, and I'm dividing the superficial and deep portions of the transverse carpal ligament in the forearm, but I'm extending into the palm underneath the skin and thenar muscles, and I'm incising the radial aspect of the transverse carpal ligament under direct visualization. And then you can see where my finger is. Once you release the carpal tunnel, you can put your finger all the way up into the carpal tunnel underneath the palm, and you decompress the carpal tunnel. So it confirms complete division of the transverse carpal ligament from its radial attachment. And what also got me very excited was by releasing the radial aspect of the transverse carpal ligament, you could retract the carpal tunnel contents, including the median nerve, without putting tension on it. So I could use smaller incisions. I could expose more of the distal radius, particularly the ulnar void portion of the distal radius, which you need to capture with a lot of ulnar column injuries. And I could do it without putting tension on the median nerve. If you don't release the carpal tunnel, and the residents fellows who've been involved, you put a Hohmann in and you try to retract the carpal tunnel contents, the median nerve, the flexor tendons, they're all tethered radially. So it limits your exposure, and you put a lot of tension on the median nerve and the flexor tendons during your retraction. If you release the transverse carpal ligament on the radial side, you can easily retract all the carpal tunnel contents without tension. So you're not manipulating and putting tension on the median nerve, which can lead to postoperative symptoms. And you get a much better exposure to the volar distal radius with this approach. So the first time I presented this approach was for trauma, because it had been presented for standard carpal tunnel syndrome by Dr. Sanders, one of my mentors at San Antonio Hand Center. I presented this for a distal radius and perilunate distal locations in 2004 at VOS and the ASSH. I had a podium presentation about this approach for the use in trauma. And as Dr. Winston Guathamy mentioned, his father literally attacked me and told me that I was crazy at VOS in 2004. So my selection of Winston Guathamy to be the resident who I wanted to help me popularize this approach was very simply face on the back that I wanted to, the fact that I wanted to get back at his dad. So, and he did tell me I was crazy, so that was not a lie. So this is how I started popularizing this approach. The first thing you needed to do was show that it was safe and that it actually did release the carpal tunnel. And this was a cadaveric study. You all recognize Lance Brunton. He was one of our residents who did his hand fellowship at Union Memorial Curtis Hand Center. And I was a visiting professor during his fellowship, early in his fellowship. So I talked about this approach, and I got Jim Higgins, who's the chief of hand there at now, and got really excited about this approach. I did a cadaver dissection when I was up there. And Ray Pensy is a hand surgeon at University of Maryland now, and he also uses this approach. But they got excited about this when I gave a presentation, and that's what started this real journey for me, is that they wanted to do a cadaver study. that shows that you can release the carpal tunnel and you can do it safely. So we compared a standard FCR approach with a hybrid approach with the FCR prophylactic carpal tunnel release, and we showed a statistically significant reduction in carpal tunnel pressure. This was a typical Mark Miller research study. I went up there for a weekend, we did a bunch of cadavers, and before we knew it, we had a paper. So the other thing is that not only was there a statistically significant reduction in carpal tunnel pressures, but we showed that the recurrent motor branch was an average of over a centimeter from the distal edge of the transverse carpal ligament. So once you release the transverse carpal ligament under visualization, you could feel the end of the transverse carpal ligament with your finger. You release it completely, you were still safe because the recurrent branch was more volar and distal to the distalmost extent of the release of this approach. So this is Dr. Glaucomy's claim to fame in the hand world, because this paper was one of the 10 most cited papers in the Journal of Hand Surgery the year it came out. So it was a retrospective study of 68 patients I treated who underwent distal raised fractures with concurrent FCR carpal tunnel release. So they had no carpal tunnel symptoms pre-op. I just did a prophylactic carpal tunnel release during my exposure through the same incision as I plate my plates, as I would put my plate for volar fixation. We had no cases of recurrent or palmar cutaneous branch injury, no cases of tendon injury. We had 2 cases of delayed median nerve symptoms that all resolved after about 3 months after surgery. So no need for reoperations. So the importance of this article, even though it was retrospective, is that it can be done safely and without concern for complications. So this was article number 2. This is article number 3. And again, Dr. Glaucomy is on this as well as Dr. Frelich and a couple of our residents and fellows from the past. But this was a cohort study where I needed to show that there is a benefit of this approach to comparing it to a traditional Henry approach. So we had cohorts of a group that underwent a traditional Henry approach without carpal tunnel release, prophylactic carpal tunnel release, compared to a approach with my approach using and doing the prophylactic carpal tunnel release. This was a prospective study, and we looked at patient-reported outcomes and particularly symptom severity score. And what we showed was, 1, there was no risk of complications. It was a safe approach. But what's more important to me was looking at patient-reported outcomes and symptom severity score improved by 6 weeks with the FCR extended carpal tunnel release approach compared to 3 months with the volar Henry approach. So to me, they returned to activities faster if I release, and they had better gains with range of motion and grip strength if I did a prophylactic carpal tunnel release in this simple cohort study. So the conclusion in this paper was that that approach is safe and efficacious with no increased surgical morbidity and can be used safely for all patients undergoing ORIF of distal raised fractures and not just in cases with concurrent carpal tunnel syndrome. So again, this was my effort to popularize. So cadaver study to show the approach was safe, retrospective study to show that there are good outcomes with no complications. And now this was a prospective cohort study comparing it to a standard Henry approach, and that there was no, I can't say that this approach is better than a Henry approach, but what I can say is that it's not worse than a Henry approach, and it can be done safely and efficaciously. And so this is another step toward trying to popularize this approach. So the 4th article is coming out soon, and it's in revision. But this is a volar distal raised exposure using 3 different surgical approaches. And to me, this is the most powerful part of this approach. And this is being done in San Antonio Hand Center and UVA Hand Center. And thank Wendy Novikov for helping with all the statistics here. But doing a cadaver study. We've completed a cadaver study where we looked at the Henry approach, an extended FCR approach without carpal tunnel release, the Orbe approach, and then a hybrid FCR approach with prophylactic carpal tunnel release. So we've done all these approaches in cadavers. We've done a computer analysis of the surface area of the volar radius exposed with each approach. And the hybrid FCR, the Chhabra approach with the carpal tunnel release, is far superior in volar radius exposure, particularly the volar radius, ulnar radius, and facet. And this is a statistically significant difference. So to me, this is the most powerful aspect of the approach. It's better exposure and less tension on the median nerve with retraction of the tendon because of the radial-sided release of the carpal tunnel. So again, this is why I do this for every case. Sometimes you can't tell whether the median nerve dysfunction is from a contusion versus a low-grade carpal tunnel syndrome, or whether a subclinical carpal tunnel syndrome. So why not release the carpal tunnel? Now, it makes sense to do a carpal tunnel release in a high-energy, significant displaced comminuted fracture with volar fragments in patients who have acute carpal tunnel syndrome on presentation. That's a no-brainer. But what about the multi-trauma and head injured patient where you can't evaluate them? You don't know if they have carpal tunnel syndrome. So why not just prophylactically release the carpal tunnel? And the vast majority of these cases are done by regional anesthesia. And they go home and they have a block. And I've already shown that there's up to an 8% chance of having post-treatment, post-acute, post-surgical carpal tunnel syndrome after disarrayed fracture fixation. So if you release the carpal tunnel prophylactically through your same incision as you're putting a volar plate in, this allows me to sleep a lot better at night because I don't have to worry about a patient having post-operative carpal tunnel syndrome that was unrecognized for 24, 36 hours because of a regional block that didn't wear off. And again, delayed carpal tunnel syndrome and complex regional pain syndrome has been shown to be present in 20% of conservatively treated distal radius fractures and up to 6% of operatively treated distal radius fractures. So there is a significant portion of patients that if you treat them for their distal radius surgically, they may have post-operative carpal tunnel syndrome. So to me, this takes care of the problem because you just prophylactically release it, even though the vast majority of these patients do not have preoperative carpal tunnel symptoms. What I do know is that many patients may have some pre-existing mild carpal tunnel syndrome. It may not be significantly different than when they present with their distal radius fracture. You put a plate on them, and then their carpal tunnel symptoms get exacerbated. So go ahead and take it out of the equation by releasing the carpal tunnel. So since 2001, every distal radius I have treated that required a volar plate or approach, I've used this technique and performed a prophylactic carpal tunnel release. I was looking over my numbers in preparation for this talk, and I stopped counting at over 1,000 cases. So this is, if I did a retrospective study, the numbers would be huge at this point. I've argued that this is how every distal radius should be treated at every opportunity I've been given. And it has been termed the Chhabra approach, but I presented it at the International Federation for Surgery Society of the Hand. I actually ran a symposium about this in Argentina. But at the ASSH, the AASS, AAOS, Singapore, India, Argentina, visiting professorships, every opportunity I get, I try to convince people using the literature that I have and that this is the way all distal radius fractures should be treated. And I have a growing number of fellows that use this approach routinely. And I've presented this at numerous visiting professorships and done cadaver dissections and showed people how to do this approach. But it has been a long time in establishing this. So again, I've tried to show the ease of the approach, the efficacy, safety, that it's a better exposure of the distal radius. I've showed retrospective data. I've showed a cohort prospective study that shows faster return to activities. But despite all of this, a prospective multi-center randomized trial comparing volar plating of distal radius fractures with and without FCR carpal tunnel release is necessary before universal acceptance and the approach becomes the standard of care. And I will keep trying to make this the standard of care, but because of past literature and because of the fact that we don't have a prospective clinical trial yet, I think it will take me longer to do so. But it is gaining popularity. A lot more people are using it. There's more articles in the literature. utilizing this approach for trauma. And again, it all started because of Dr. Frank Wathme and my wish to get back at him by using his son to help me popularize this approach. So thank you very much for allowing me to present this journey. And I hope those of you who are not hand surgeons found this interesting as well. But I do think that it shows what you need to do from a research and literature and standpoint if you want to change the standard of care. So I'm open to any questions now.
Bobby, thank you that was awesome. I remember taking all those pictures and put all that together. It just goes to show as a resident, I mean, you can actually do some really positive things when you're a resident. I don't think I've done anything that's had that much meaning as a faculty member as I had when I was a resident with Dr. Chhabra. So thank you for making me a part of that. Lance Brunton really was the one who got me super involved in that. And so he was my chief resident when I was a PGY1. Just goes to show kind of how you can have residents working together to do some cool things. Couple of things. One, you referenced multiple times how you sleep at night better, and nobody thinks you actually sleep at night. So that was just a comment more than anything. A question for the audience. There's hand surgeons on the audience here. Anybody want to go out on a limb why they don't release a carpal tunnel? I think Dr. Deal, do you release a carpal tunnel for all your distal radius fractures, or Dr. Dacus? So I think that Dr. Frillick does, but Nicole? No.
Hey, I'm here. Sorry.
What are your thoughts, Nicole?
Yeah, so I don't do that approach, although I respect the thought process very much. You're laughing, Winston. Yes,
I'm not
you
laughing.
So you know, the one thing I can mention is that there is some reservations by people to do this because you know, you have to learn the approach, but once you become comfortable with it, it adds about 5 to, you know, less than 10 minutes to your surgery. One of the most common questions that I get is, do I bill for a carpal tunnel release with this approach? And I do not, unless they have pre-existing carpal tunnel symptoms or they have acute carpal tunnel syndrome.
But you can't, Bobby, right? Unless they have pre-existing symptoms, right?
I do not bill for it. It's part of my approach.
Yeah, you cannot. My reasoning for not routinely doing it is cosmesis. And so, you know, I think that it's I close my distal radius fractures with a absorbable monocryl. And so people really do have a nice cosmetic scar at, you know, a few months after surgery. I recall, and it's not an ugly scar, please don't misunderstand me. I was in line with someone at a grocery store somewhere, and I was like, oh, did you have a distal radius fixed by Dr. Chhabra? And she was like, yes. And she had a Harry Potter Z, you know, on her forearm. And I was like, oh, wow, you know. So that's my logic. Unless I really need a carpal tunnel release, that's the reason I don't do it.
So that's a very good point. So I use that approach because it does allow me to release the carpal tunnel and that incision is a relaxing incision, and usually by 3 months it's a little hypertrophic, but by 6 months you can barely see it in most people. So I can understand the cosmesis, but it's too hard to do that with a straight linear approach. You have to have flaps so you can get to the FCR and FPL. And that's why I have to use that more of a Brunner type approach rather than a straight longitudinal approach.
Oh,
but you're right.
Completely understand. Yeah. So yeah, I get it. And yeah, and I think it's a great approach.
When I was tracking down those patients for that paper and they didn't know who their surgeon was, I looked at their arm, and if it was a straight incision, then I excluded them. But if they had the quote Harry Potter incision, I knew they were one of mine. So I like that term, Nicole.
I think that once the paper comes out soon about the exposure of the volar radius, I think there will be potentially more people interested in doing this approach for the simple fact that it's sometimes hard to capture that volar ulnar portion of the distal radius with
Yeah.
the plate because you're trying to retract against the tethered carpal tunnel contents. So I do think that the acceptance for certain fracture patterns will increase once we can show that the exposure is better with this approach of the volar radius.
Dr. Kui asks, is the approach cost effective? Are there any issues with insurance?
No, because I don't charge for it. So it's the same code as any other volar plating of the distal radius. It is part of my exposure. So there's no charge, there's no insurance issues, and it's just billed as a standard ORIF of the distal radius.
But Bobby, if they do have preoperative carpal tunnel symptoms, you could add that as a code and bill for it.
No, I do that,
Yeah.
Nicole. That's a good question. If they're coming to the OR with acute carpal tunnel symptoms, I actually put in the preoperative diagnosis acute carpal tunnel syndrome, and I still use the same approach, but I bill for a carpal tunnel release in addition to ORF of distal radius. But if they do not have pre-existing carpal tunnel symptoms, I do not bill for a carpal tunnel release.
That's
Nicole,
fair.
if you have a patient with a distal radius fracture who's got progressive carpal tunnel syndrome, how would you approach that? Would you do a disc approach? Would you do a 2-incision or?
I do 2-incision. Yeah, which is not as nice as the way Bobby does it. I very rarely do I have a patient who has these concomitant symptoms because we have waited, we typically stage them so they're reduced in the ER by our amazing residents, and then their symptoms will resolve and then we see them in the OR. So very infrequently do I have a patient who has these carpal tunnel and distal radius symptoms at the same time. So I'll typically make another incision if I need to, and that would be more in the acute setting. But yeah, so I do 2 incisions.
Dr. Weiss asks, can a carpal tunnel release be done through an Orbe extended FCR approach with the same visualization, or does the Brunner incision give better exposure?
So I've tried to do it through the Orbe extended approach, and the Brunner incision gives more, it just gives me more exposure to the radial side of the wrist by lifting that radial flap. So you can do it through an Orbe approach, but if you look at the Orbe approach, he actually crosses the wrist crease, and I try to avoid doing that.
Yeah. And sometimes you have to do that. And the way that I would do that is make a transverse incision at the wrist crease and then extend it up to the carpal tunnel. The Orbe approach is actually the Chhabra approach, to be honest. So, that was adapted from Bobby Chhabra's work. So
Orbe takes credit for it, but he has his own plane and he's worth tens of millions of dollars. So.
Correct. My point exactly. But this is really the Bobby Chhabra approach. Weiss.
Oh, I don't see more questions. I think I can speak.
Hey, Dr. Chhabra, this is this is Pat. I have a quick question for you.
Trace.
So last night on the ASSH lecture series was about complex distal radius fractures, and the surgeon lecturing talked about the volar ulnar corner a lot. And he said that every time he has a fracture there, he does the extended volar ulnar incision where he goes in between the FCU and the flexor tendons and then crosses the wrist crease to go through the carpal tunnel as well. Do you see any indication for this compared to your approach? Because I know you can also see the volar ulnar corner really well on your approach. What do you think about that other approach?
Yeah. So that has been popularized by several surgeons, including Mel Rosenwasser at Columbia. I think that approach is crazy to go ulnar to the carpal tunnel contents and then cross the wrist crease to get exposure. They're not even releasing the carpal tunnel when they often do that approach. So you can get the same exposure by just releasing the radial aspect of the carpal tunnel through the extended FCR carpal tunnel approach. And I think your exposure is more than adequate. So I think this is a much more versatile approach than an ulnar-sided approach to the distal radius, in my opinion. And there's less risk to the ulnar, to the median nerve, because you're so radial. And
you have to be really careful with that, Pat.
Yeah, I just don't understand that approach when you can do this and still get adequate exposure of the volar radius. So again, hopefully when this paper comes out, and if people will read it, they'll see the versatility of this approach.
But also, Pat, I mean, if you go ulnar to FCR and you're careful of the palmar cutaneous nerve, just, you can get to the volar ulnar corner of the radius from a standard volar approach anyway. So, I mean, just be real careful doing anything that's not tried and true and proven, you know?
From Dr.
Yeah, I
Singla.
agree with you guys. I just wanted to see what your point of view was on.
Yeah.
So from Dr. Singla, is there any consensus to release the carpal tunnel for high energy trauma cases?
Oh, I think you should automatically release the carpal tunnel for any high energy case, particularly someone who's intubated, someone who's in the unit. You don't have a good exam. Their volar forearm is very swollen. You have a highly fragmented distal radius fracture, interarticular comminuted distal radius fracture, significant extension into the metaphysis. No matter how you do it, whether it's through my approach or through 2 incisions with an incision carpal tunnel release in the palm, I think that is absolutely indicated in high energy.
I agree with you 100%, Bobby. Yeah.
Dr. Whipple?
Dr. Chhabra, from a cosmetic consideration, couldn't this Brunner incision be closed with 3 separate subcuticular linear sutures?
You absolutely, and I have done that in certain individuals. The one other advantage to doing a Brunner incision, and I actually did this in the lab, is that you can make it a little shorter to put a plate in than a standard longitudinal Henry incision, because once you release the transverse carpal, the radial aspect of the carpal tunnel, and it's easier to retract contents to put your plate on. So you can actually get away with making an even shorter incision than a standard Henry approach for this. And you can close it with subcuticulars as well. That's not an issue.
So from Dr. Weiss, given the common nature of distal radius fractures, why is there resistance to a multi-center randomized controlled trial? Numbers should be very easy to get.
There's no resistance, really. It's just a matter of coordinating this and with multiple centers. And I think there's enough people out there that's doing this now that I can do that. I think from my standpoint, it's been a matter of finding the time to organize a trial of this magnitude.
Bobby, why? You don't have anything else to do? I mean, you're not busy or anything.
Well, no, but I do think there's enough people doing it routinely that finding numbers will not be a problem. But that will be the next step of the study, is now we've looked at everything, cadaveric, retrospective, prospective cohort, and now the benefits of how it maximizes exposure of the volar distal radius. The last step in this, I guess, research algorithm is doing a prospective randomized clinical trial. And I need to get, I got to get a grant to do that as well. As a multi-center trial, you need to have some funding of this magnitude, and you should be able to get statistically significant numbers very quickly.
Any more questions? Oh, Hamid thinks the problem is C7. You have to look at the neck on all of these.
Yeah, yes, of course. It's always, we can now, let me figure out how I can do this approach and also decompress the C6-7 disc space through this approach, and then we'll solve everything.
The spine guys need more RVUs, I think. Well, I think if there are no more questions, I think I speak for everybody. Dr. Chhabra, thank you for this lecture and for everything you're doing.
Thanks so much, Bobby.
I bet you probably prefer talking this than N95 masks and proning patients. But
I'll tell you, the one thing I regret the most as my career has developed here at UVA is that I don't get to teach as much as I have done in the past and that I like to do. So given the opportunity to give these grand rounds today, although it was unfortunate because Dr. Hammer couldn't be here, but given this opportunity, it just reminds me of why I went into academic medicine. I love teaching, and I really appreciate the opportunity to talk about these give these 2 talks today. And I hope they were interesting to more of the wide audience and not just the hand surgeons. But you can have a very, thanks, Nicole, but you can do some very interesting non-basic science studies and clinical research projects, and that can have major contributions to the literature if you continue to be persistent. So thank you very much.
Certainly a reason why residents from UVA tend to gravitate toward the hand, myself included. You've been an inspiration to all of us. So thank you, Dr. Chabra.
Yes.
And I
thanks,
look forward to seeing everybody next time. Okay?
Thanks,
Thank
Winston.
you, Bobby, and thank you, Winston, for setting it up.
Hey, Winston, I have a question. Can you separate these two talks